Hey folks, Scott Weingart here, and this is the EMCrit podcast. You know what I've been hearing for 10 years, for a friggin' decade? Scott, where's the OB emergency? Scott, where's the OB emergency? Scott, we want to hear about OBGYN emergencies. Why is there no OBGYN stuff on EMCrit? And I get it, I wanted it too, but I'm certainly not the person who is smart enough to talk about this stuff. I have no idea. And I was looking for someone who would give us a true critical care perspective on OB. And someone finally fell into my lap. And that person is Sholene Espinoza. And what happened is she wrote me and said, hey, you might be interested in this. It's a YouTube video of a talk I had given back at my alma mater where I trained in OB. You probably don't have time, but if you listen, you might like it. Because I've been listening to EMCrit for years and you've really inspired me. And hopefully, I could inspire you a little. And God damn it, did she ever? Because I was like jaw on the floor listening to this because she was just talking about her career. So let's talk a little bit about Sho's career. So at 17, she joined the Air Force, was told women are never going to fly combat missions. And so, of course, she wound up flying combat missions in, badass combat planes. And then after the military, she decided to become a commercial airline pilot. So she flew big jumbo jets. Then war correspondent. Okay, well, what next? Might as well go back to medical school. Of course, why wouldn't you after that career? Makes complete sense. Go back to med school. All right, so med school, OBGYN residency. That's probably enough, right? Just stop there. Nope, of course not. Let's do a surgical critical care fellowship. So Sho is the best person in the universe to talk about OBGYN emergencies on EMCrit. I'm hoping she becomes, if she's willing, the OBGYN editor on EMCrit. And she is friggin' amazing. So she is still a surgical critical care doc and a laborist at the Cleveland Clinic. She is still a member of the Pennsylvania Air National Guard doing critical care air transport. She is a complete and total badass. And as you listen to her, you will see, wow, it's just like fate gave me the perfect person to bring on EMCrit and talk about these issues. So today, to start it off, we'll talk about postpartum hemorrhage. And at the beginning of the episode, I say, this is not really relevant to me. I've only worked in places with OB. I only work in level 1 trauma centers. They all have OB services. And I'm like, this is never going to be relevant for me, but I want to do it for my listeners, for the rural folks who might not have an OBGYN for 100 miles from where they're at. And if a patient delivers and starts hemorrhaging, they're going to be the ones, not the OBGYNs. So I wanted to do the episode. And of course, as soon as I uttered that, this was after the recording, but before me releasing it, one of my institutions lost its OB service due to a Department of Health survey. They just don't have OB for a few months. And so now we had to retrain for postpartum hemorrhage and such. So this is now directly relevant to me as well. This is a long one. It is completely worth it. I've listened to this multiple times now, and I'm entranced every time listening to Sho talk because it's exactly what I want. It's no bullshit. It's not like, head in the clouds, ivory tower shit. This is like how to actually get it done from a true resuscitationist. So I think you're going to love it. Now, I have an apology. My mic was wrong. I violated the cardinal rule of podcasting, which is when you have a good podcasting setup, you never F with it. It's just too important. And I F with it. Now, I didn't F with my podcast setup. What I had done is I wanted to install another mic below my monitor for my AI work because it's so much easier to dictate to AI. And I was sick of having to keep bringing the real podcasting mic in front of my face. AI is good enough. It doesn't need a mic right up against you. I just wanted something I could talk at any moment. I just press one key on my keyboard. I could talk to my AI. So I added that new mic. And of course, Zoom decided to use that new mic rather than my existing one. So my audio is not great. It's not horrible. It's definitely usable, but it's not up to snuff. It's not up to EMCrit standards. It doesn't matter. I did very little speaking. Sho's audio is great. And so that's what's important. So you'll hear from Sho Espinoza on postpartum hemorrhage. You'll hear me occasionally popping in with irrelevant tangents, and you're going to love it, I think. Now, incredibly quickly before we get into that, 2 conferences are selling out. Reanimate, just a few tickets left. If you're interested in Reanimate, now is the time, both for docs and knock docs. It's going to happen 3 months from now in San Diego. You can check that out at reanimateconference.com. But seriously, if you want to come, buy your tickets right now because They are going to sell out, and then you're going to be pissed. And you're going to be like, wait, I didn't know it was going to sell out. I've only told you like 1,000 times. And then we're about to sell out, thanks to all of you, to our burnout course, which is a synchronous video course on burnout called the Unburnable course. And you can find out information about that at unburnablecourse.com. So if you were thinking about that one, we just have a few tickets left for that as well. So reanimateconference.com, unburnablecourse.com. Go to the sites, check it out. And if you're interested, buy now, because otherwise you're not going to be able to, and you're going to be so sad. All right, let's get into Sholene Espinoza, aka affectionately known as Sho, on postpartum hemorrhage. Oh, and that video she had sent me, I linked that in the show notes. After you listen to her, go watch her video, because then you'll be like blown away by the crap she has done. Amazing. All right, postpartum hemorrhage, let's jump in. All right, so we'll start off with the same question I ask everyone. Who are you and what do you do?
I'm Sholene Espinoza. I work at the Cleveland Clinic in Cleveland, Ohio as an intensivist in the surgical ICU and cardiac ICU. And I'm also an OBGYN and do a little bit of critical care OB there, but mostly laborist on call in the hospital for OB patients.
Amazing. And for so many reasons, you are the exact kind of resuscitationist that we love here on EMCrit. So you are the perfect person to talk about life-threatening critical care situations in OB patients, because you have both the obstetrics GYN background as well as surgical critical care and a resus mindset. So we're going to talk today about postpartum hemorrhage, which at the places I work at, it's someone else's problem. I never even get exposed to them. If they wind up coming into the ED, they're whisked upstairs almost immediately, because I have the benefit of 24-hour OB. A lot of places across the country, they do not. They might be the only docs taking care of a woman who has just given birth and now is exsanguinating. So we're going to put ourselves in that mindset, and we're going to start working through this. So I guess I'd ask you first, what are the risk factors for a patient having postpartum hemorrhage?
They're numerous. Sometimes when I think of OB, I try to risk stratify it based off of it's either mom or the uterus or the baby. So as far as mom's concerned, she could have a coagulopathy. She could have some type of coagulation factor deficiency, von Willebrand's, what have you. And that'll put her at risk for bleeding. Even a couple of weeks out or a week out could be that. The other thing is when you think about uterus, clearly tone is probably the biggest thing. You've got 500 cc's of blood going to that uterus every minute during pregnancy. And so really to save mom's life is dependent on contraction of that uterus. And that contraction, those little myometrial cells act like little tourniquets on those uterine arterioles. And if that doesn't happen, then you just get this massive lake of blood. So you can have atony. You can also, in terms of the uterus, you can have retained products or abnormal placentation. We see that more nowadays with so-called accretive spectrum disorders, where there's the placenta is invading into the uterus. And even if she delivered and then might come back because there was some placenta left in there, so retained products. Trauma is another one. Trauma to the uterus. You can have some kind of a placental abruption, can have it as well. And then, so we have the four T's of the tone, the tissue, the trauma.
And we'll get to those for sure, yep.
And the thrombin, so to speak. And then as far as too is somewhat of a risk factor, especially out in rural America. I've seen cases where a mom is at home and she has a placental abruption because she's had a previous history of cesarean section, goes into labor, and then that uterus gives way and has a massive hemorrhage in that setting.
Absolutely. All right. And then I guess we should define what postpartum hemorrhage, what the cutoff is. I've heard 500, I think 1,000 cc's of blood is more commonly used. What do you cut it off? Or is it really just looks like an LLS score, looks like shit score of like, oh, that's a lot of blood. This is postpartum hemorrhage that I have to worry about. What's your cutoff, Joe?
That's a great point, Scott, the LLS score. I think that over-indexing on these numbers sometimes ties our hands. There's some great data from the California folks and talking about maternal hemorrhage. There's also ACOG defines it technically as a liter blood loss. We used to be 500 vaginal and a liter for cesarean section, and then primary being in the first 24 hours and then secondary being 24 hours after that, up to even 12 weeks. But the biggest thing is that people don't really think about is any change in hemodynamics for the patient. So I always think of these patients, kind of the trauma patients, in terms of there's no level 3 or stage 3 of hemorrhage. It's like they go from 2 to 4. They go from 2 to off the cliff very quickly.
All right. I imagine at your place, you guys call in a team if this occurs. Is that right?
Yes.
Okay. Who's on the team at a real level 1 type center? And then we could extrapolate that to what to do in the environments that don't have that many. So who comes if you call a postpartum hemorrhage code?
Yes, you have a OBERT team or OB emergency team, then you're going to have typically, obviously, an OB. Whoever the OB is in house, you'll have anesthesia in house, and depending on the situation, you'll have a trauma surgeon plus or minus. And I think that is a variable. Gen surge, in terms of, let's say, just say if we put it into the OR scenario, you're in the OR and things are not going well. Obviously, you've already got an OB, you have an anesthesiologist, but I would advocate to, if your trauma surgeons are not going to your postpartum hemorrhages or big hemorrhage situation, sure, they're not going to come in and fix a bowel or bladder injury that you made in a C-section, but if the mom is bleeding, there's no better person than an acute care surgeon or trauma surgeon to help out.
Interesting. Now that makes complete sense, and yet I imagine a lot of times they're not going to be utilized. So would it be workable to have a tiered system where, because a lot of these will respond just to the oxytocin and the massage. And when you say it's variable, do you want the trauma surgeon coming to each of these calls, or would it be one where you put out a call, we need them now?
I think obviously risk stratifying, for example, do you have it under control? I guess the question would be are we going the right direction or the wrong direction?
Yeah.
If we are still behind, and let's say, for example, there was a case recently where this patient had HELP syndrome and then she had a liver hematoma and she was acutely bleeding in that scenario. Okay. So the OB is probably the garden variety OB is not going to be able to fix that and pack the liver. We certainly can. We have laparotomy privileges. We can certainly do that. But that temporizing measure of being able to stop that bleeding with tamponade would be helpful. On the other hand, a placenta accreta spectrum disorder, you can lose 6 liters of blood pretty quickly. So in that scenario, gyn-onc is usually the people that are going to come in. But one temporizing measure that I always say is, if you are at a critical access hospital, sometimes it's a general surgeon that's doing these cases. One thing that you can do is compress that aorta against the sacrum, right? So if the patient has already got a belly open, then you just palpate that sacrum. Anyone can find a sacrum and feel that aorta pulsating and compress that. I kind of think of it like a Roboa. You could do that I've done it up to 40 minutes while I'm letting the anesthesiologist catch up, and then all of a sudden we're in a much better place. Externally, you can do that too. Just your fist just offset to the left side of the umbilicus. I think you've done a lot of work on that on EMCrit about these temporizing measures that can be life-saving.
I love it. All right, so let's say you had all 3 of these people show up, an OB, an anesthesiologist, and a gen surgeon or a trauma surgeon. Who's actually running the resuscitation at that point? Because I imagine the OB is going to want to be doing all of the procedures down below. They can't have a 360 view. So who runs the massive transfusion, the determination of blood products, what's needed, and all of that in that scenario?
I learned a lot of critical care myself and obstetrics from anesthesiology folks, in that they are typically, when we think of what's going on in an OR, they are typically the ones that are running the resuscitation. The trauma surgeon's going to have an input, for example, but in these scenarios, but by and large, it's our anesthesia colleagues that are going to be running the actual resuscitation. And then the OBs and the trauma surgeons are going to be focusing on source control.
That makes absolutely. All right. So let's get to the 4 T's, or the Brits now are talking about 5 T's. They add theater to that to stress going to the OR. I would say there needs to be a 6 T there for things like tamponade should be on that list, I think. And then there needs to be another T, but I don't know what it would stand for, the cross-clamping or aortic conclusion, with it being an internal cross-clamp through Roboa. So I think the 4T model, it needs some adaptation because there's some other ones on there. But maybe as we're going, we can brainstorm what we should be calling it. Hey, future Weingart here, just popping in. At the end of this all, I think there's 9 T's. Now, I don't know if this is going to catch on, but this is what makes sense to me. 9 T's. So the first 4 are the classic ones discussed all over the OB literature. So you got tone, uterine tone, tissue, retained tissue, trauma to the reproductive canal, thrombin, some form of induced or baseline clotting issues. So those are the first four. Then I think you add in transfuse, because we really should talk about the specifics of transfusing a critically ill OB patient. 6 is tube. We should consider the unique circumstances of tubing a patient like this. Hemodynamically, really dangerous, but also the fact that a lot of these third trimester pregnancies should be considered difficult airways from anatomy and physiology. So that's your tube. Number 7, there definitely should be a T for tamponade, and that's uterine packing, or a device that's going to fill the uterus, or the new devices that will actually vacuum down the uterus to try to induce collapse of the uterus. So that's all under tamponade. Number 8, temporary aortic occlusion, whether that be external or internal direct compression of the aorta, or internal filling of the aortic lumen with a Reboa balloon. And then the last T is for theater or transfer, going to the OR, the IR suite, or transferring to another institution if that's viable. All right, so 9 T's, but we're going to discuss the first T. But let's start with the consistent first one, which is tone. All right, so let's talk about uterine tone. So how are you going to assess the lack of uterine tone, and what are you going to do to intervene on it, Joe?
Uterine tone is the most common of the issues. So if I'm thinking about like, what would be the scenario of someone coming in with poor tone, potentially they delivered en route to this critical access hospital or what have you, a rural hospital. And it wasn't like they planned to deliver, but so usually just a boggy uterus. You're feeling the top of the uterus feels like a big muscle, and that should be feeling firm. You can also have the fundus, the top of the uterus is firm, but the lower segment is not, and it's floppy. And the biggest thing that obviously that we do is we use uterotonics. I always say don't over-index on the uterotonics. Give them. So we're talking about Pitocin. Remember that if you got a first trimester bleeding situation, which is a little bit different, those oxytocin receptors are not really active until about 13 weeks. So they're not really very helpful in the first trimester if you got a bleeder there. Then you have your augments, Methergin, which you can give, and Hemabate. They have some contraindications, Methergin, if you're super hypertensive or you have some cardiac pathology. And then Hemabate would be asthma or respiratory issues. So Methergin is the organavine. That's going to be 0.2 milligrams IM. There's a PO version, but it's not going to be as effective. And that Methergin is very effective in the first trimester as well. And it starts to work pretty quickly, just within minutes. Hemabate, which is the long name, it's this 15-methyl PGF2A. It's like a prostaglandin. I'm reading this, of course. That's 250 mics, and that's also IM, but that takes about 30 minutes to work. And you can use several doses of that, whereas Gen, you want to wait 2 to 4 hours, whereas Hemabate.
Let's delve into this a little bit more, because I really want people to understand. So everyone in the postpartum, the third trimester delivery, is going to be getting oxytocin. How do you deliver that?
You can do 10 units IM. And I find, and I've worked in South Sudan and different places. I'm also a military doc. Let's not get too technical. You can just give 10 units IM and that'll work. Or you can do 10 to 40 units in a liter and then bolus initially about 250 and then run it over time. It doesn't have to be elegant, just get it in.
Now, this has always baffled me, Joe, and maybe you could clarify, because it makes no sense. And when I hear stuff like this, it never makes sense. And then usually it distills down to people just didn't work through what happens in an emergency. If we're able to bolus it, IV, and you're saying give 250, which if you put 40 in that liter is 10, can we just give 10 IV?
That's a great question. The issue is too much can cause hypotension, and you can get these hyponatremia and other effects. Harvard did a study. I'm sure there were other people involved. I call it 3 for 3, basically 3 units IV, wait 3 minutes, and then you can do it 3 times. And I've seen that work extremely well. I'm not a big, huge bolus kind of fan. I've seen some badness. You do a lot of critical care. I've seen people go into cardiac arrest. These are more technical cases
Mhm.
when you have someone with a congenital cardiac issue and they get a big bolus of Pitocin by the weekend covering anesthesiologist. That's no bueno. But that 3 units is safe. And then wait 3 minutes, you usually get the tone. And then again, you can do it up to 3 times.
That's brilliant and seems far more appealing to me because I really am scared of a patient in shock giving IM meds and hoping those are going to work. We've proven in anaphylaxis that in general, it's not a great way to go. That 333 seems like a great way. Would that be accepted if people were reviewing this case and nobody looked at it and they're like, what the hell are they doing? You can't give oxytocin like that. Or is it now it's standardized? That would be okay.
I think that's a standardized protocol. I haven't ever had any issues in the OR with anesthesiologists looking at that.
All right, cool. Now, let's say the patient does look like, we'll say crap just for, so not to offend people's ears. The patient does look like crap. Are you just given the whole kitchen sink if they don't have contraindications of the oxytonics at that point? Or is it a stage type thing where it's like, all right, we're 10 minutes in, they're still not where we want. Would you just give the other two you mentioned or no?
I think that the Methergen, the methyl ergotamine, giving that, let's say, even if the patient had a hypertensive disorder of pregnancy and they're now hypovolemic and hypotensive shock, I don't think they're going to go into cardiac arrest from that. Have I ever done it? Yes, I've done it. The hemabate, I would use caution with. I have seen people with just asthma or even sort of exercise-induced asthma have issues with the hemabate. So I'm not a fan. I'm more of a fan, probably my military background, of compression and is just getting my hand in there and do bimanual compression. And what that simply means is that you're feeling the top of the uterus just like a muscle, and you're putting your hand, I flip the cervix behind it, and then just literally compress the uterus down as if I'm just holding pressure on like making it like a holiday ham, if you will. And I have sat there and done that even when in tertiary care centers for 30 minutes, waiting for those uterotonics to take effect and waiting for the resuscitation. I will say, I think something that's underappreciated is that bleeding causes dysfunction of the blood system, right? I think you've talked about this a lot in your trauma work, in that you become coagulopathic, obviously, with bleeding. And that also, I think, affects tone. So it gives you a chance to resuscitate the patient with regard to your coagulation factors. And also, you're going to have a better chance of fixing that tone. When you're bleeding, I think it sort of begets more apnea.
I love it. All right. Now, I want to just finish up on the oxytonics and make sure we really got it. And then we'll go back a little bit to the massage because I think both of those are incredibly important. So what I'm hearing is if a patient is really bad off, we could do the 3x3 of the oxytocin. You would empirically give Methergen to pretty much anyone in this state lacking those cardiac abnormalities. And you'd probably give them the hemabate. Am I getting it correctly?
Unless if they don't have any kind of respiratory history like asthma or COVID, for example, when we saw that. So you can definitely give the hemabate for sure. It's just going to take about 30 minutes to work potentially.
Okay, so let's say they were sick and they don't have any of the respiratory contraindications. Would you just add that hemabate up front because you know it's going to take 30 minutes and so you might as well get it in? Is there any downside if they don't have contraindications?
No, I think it's definitely use that. The Cytotex misoprostol, which we use off-label, obviously, that is another uterotonic, but doesn't have the contraindication with asthma. So it breaks down into something that doesn't create the vascular issues.
So how does that fit into the mix then? Sure.
So that can be given rectal, and that's an easy one. You can do 800 to 1,000 rectal, or you can do sublingual or buccal 400. I'm not a big fan of the buccal, even though your absorption is faster and they say it works better. But with your respiratory or with your intubation experience, like you don't want to be intubating someone with chalk in their mouth.
Yes.
So, which is usually a lot of times where this is going. So potentially in worst case. So 800 to 1,000 rectal, and that'll take about 30 minutes to work as well.
And is that in lieu of the hemabate or in addition to?
My sort of thinking is I'll do Pitocin, Methergin, then I'll stick that misoprostol, have someone put it in because my fist is usually trying to
Yep.
manually compress the uterus, have them put that in the rectum, and then Hemabate next. Hemabate, just as a warning to your listeners, does cause pretty profuse diarrhea, so that could be followed up at some point with some antidiarrheal medications.
Okay, and so I really just want to lock this down. So you would give both misoprostol and Hemabate as long as the patient didn't have the asthma respiratory contraindication. You do both.
Yes, you
Okay.
can. When you're reviewing cases, a lot of times it'll be like, did they give everything that was not contraindicated? And the other thing is our friend TXA, got to bring it up because I'm a big fan of early TXA. Obviously, all the studies and everything in TXA, the earlier you give it, the better off you are. There was the woman trial, WOMAN trial, that in the sub-analysis showed a decrease in mortality, but there's been a lot of studies. Oh, it doesn't help that much. As we know, this is a normal distribution. You're not going to see a signal in everything. I have seen it help. I give it right up front with all these other medications. One gram, just like you would in any other trauma situation, and you can redose if needed, a second gram if needed. We haven't shown any increase in thrombosis or seizure or any of those other maladies.
All right. So I think we got that locked down. Let's talk about this massage. So one hand is going to be external, and you're just going to be grinding your fist in there. Joe, is that the idea?
Yes, I'll cup my hands, like the fingers out as if I'm like maybe trying to balance a tennis ball, if you will. And then flip the cervix, because a lot of times, let's say the cervix is dilated, you're like, wait, my hand is in the uterus itself. And so I'll feel the posterior lip of the cervix, I'll flip that up and then compress that. And if you're having a hard time, yes.
What are you doing with the external hand?
I'm just feeling the top of the uterus. I'm just my hand is just flat and scooping them together, just like yeah.
And now, is there just constant inwards pressure, or are you doing it rhythmically? Like massage generally denotes like
the uterine massage. I think the typical is people are like, I'm massaging the uterus. I think that's helpful. Sure, it's making the uterus wake up, if you will. But at the end of the day, you have to APOSE, APPOSE, those tissues. And so I'm just literally compressing them as hard as I can.
So you're not bothering with the massage aspect of it. You're just doing compression.
If I'm going to put my hand in there. Otherwise, if I'm not going to put my hand in there, then a massage is fine. Is what the typical is. And then, of course, you want to gown up because you are going to have blood and you're introducing bacteria in there, not just you being at risk, but the patient.
Yep.
And then in terms of how to make mom comfortable, I'd like, if you can, ketamine is beautiful, but some people will balk at that. It depends on where her hemodynamics are, but just in someone who's okay-ish and not like you're not thinking of intubating them or something because they're in such bad shape. Obviously, resuscitate first before that, as you always emphasize on your podcast. But you can 1 of Versed and 50 of fentanyl if you're not in a place where, or even just 50 of fentanyl can help. But I like the Versed because it's relatively stable and they don't remember all this badness typically.
I love it. This was a question on my list. So you could absolutely get the patient in a dissociative state with the ketamine, and that's not going to have any. The mother's not contributing at this point. You're not asking them to do anything. Is that right, Joe? They're not. It's not like when during the delivery we need them awake to push. They're pretty much a passive participant at this stage of the game.
That's right.
All right, future Weingart here. Now, as is my wont, and probably as you expected, I could not let this stuff lie with the uterotonics. It just seems too all over the place in the OB literature, not in Show's description. She is dead on what she would do, but it just doesn't make sense to me. And like when I go to the ACOG, the American College of Obstetrics and Gynecology, like I just keep going backwards in their recommendations and trying to find some discrete, here's what to do, not as a definitive statement, but at least as guidelines. And it just keeps referencing their previous guidelines, and I keep going back, and it references papers that just talk about the lack of great evidence. And I'm with them. The evidence is not great for any of this stuff, but you got to give people a recommendation, especially when we're talking about services that aren't OBGYN, like emergency docs who are going to see this because there's no OBGYNs at their place, maybe for 100 miles. So I delved into the literature on this, and here's what I came up with. Now, I'm not saying do any of this. I'm saying talk to either your OBGYN service or whichever like your big receiving center is, and like maybe get together and talk this stuff through, because I think there are better ways than what's out there in the standard OB literature for guidelines supported by the actual studies. So let's first talk oxytocin. Again, it makes no sense to me ever to give anything IM in a crashing patient. They do not have the peripheral absorption. If you have a crashing anaphylaxis patient, you immediately switch to IV because IM is not going to get you where you need to go. And it's known that this can be given IV because everyone's talking about giving it as a bolus in a bag of fluid. Now, that's another thing that's always a shit show during a resuscitation, is putting something in a bag of fluid and letting it run. This is very much akin to the dirty epi drip, which I just think is the dumbest thing in the world. So I don't like that either. Now, could you just push this? And now, when you look at the literature in C-section patients who are getting spinals, there definitely is hypotension, tachycardia, question of, EKG changes. There was one randomized controlled trial I found where they had healthy patients and they gave this, and these patients also got a little bit hypotensive and tachycardic. So, it doesn't sound great. Now, that study, they were giving it rapidly, just as like a slam push. Now, that doesn't seem good. Now, then you look at stuff like the WHO, the World Health Organization, and they recommend 10 IU, 10 units of oxytocin given over 1 to 2 minutes. And they actually recommend that instead of IM for a patient who's actually having postpartum hemorrhage. And in a patient who got it for prophylaxis, they actually recommend giving the 10 IV even if they got the IM. Now, you got to understand, so much of this literature comes from the prophylaxis data of normal deliveries that they're giving this to avoid postpartum hemorrhage. So when you're seeing stuff like that, it can't necessarily be extrapolated to patients who actually are in postpartum hemorrhage. And so you have to look at that literature specifically. And so there was an RCT actually looking at this, and this RCT looked at 10 units pushed over a minute. And it was superior to IM, and those patients did not have the hemodynamic consequences. Well, that seems appealing. Now, Show's recommendation of 3 for 3 also makes a lot of sense. That's going to give it over about 10 minutes, right? You give 3, you wait 3 minutes, you give another 3, wait, and I'd still not push that in slammed. I'd still give that as a slow push over like 10, 20 seconds. Well, that sounds good. What else sounds good? Putting 10 units in 100 mLs of NS and just letting that free flow in is fine by me. It's going to go in over, a couple of minutes. That sounds good. I mean, the best of all worlds would be a slow push over 1 to 2 minutes. Problem is, no one does that. When you say give it a slow push, they mean over 10 to 20 seconds. Even if you tell them give it over, 1 to 2 minutes, it's always 10 to 20 seconds. So that doesn't seem like the best way to go. So something along those lines, either as a push dose, as a slow push, as 3 units, wait a couple minutes, 3 units, wait a couple minutes. I think you'd be in very good shape, because her 3 for 3 that Show mentions, that was also done in healthy patients for prophylaxis. I think you're going to want it in a little bit quicker for PPH. So maybe giving 3 units, waiting a minute, 3 units, waiting a minute, 3 units, waiting a minute. You would be golden compared to the RCTs that were just giving it over a minute, which also seemed to be safe. I like that much better than IM. And then you absolutely could then start the other 30 units just running on a pump if they're still in uterine atony. What about the Methergin, the methyl ergonovine? That is another IM medication, but I have an RCT where they gave 0.2 milligrams IV over 30 seconds and had no problem. And that seems really appealing. These two I like a lot, oxytocin and the Methergin, because they work quickly, right? Onset within minutes. And so I like giving these two IV. I'm not saying do this. I'm saying I have randomized controlled data saying it's okay, and you should talk to your OB service, because that makes a lot of sense to me. Oxytocin IV, Methergin IV. And Show's point is well taken. Don't give this for patients for prophylaxis who are having hypertension of pregnancy or preeclampsia, obviously. But if those same patients got significantly hypotensive from postpartum hemorrhage, then you absolutely are back to being able to give it. So maybe the only person you wouldn't want to give it to is patients with intrinsic cardiac pathology. All right. Now, the carboprost, the Hemabate, this doesn't seem like a great show. First of all, you have the contraindications in the patients with the respiratory disease, the asthma, the reactive airway, COVID, as Joe mentioned. So you got that, but then it's not going to work for 30 minutes, and the profuse diarrhea does not sound like a great thing. Now, I don't know if that means don't give it, but the misoprostol seems more appealing, right? Like you're like, oh, I don't want to have to deal with the timing of a rectal dose. Well, it's going to be 30 minutes even if you gave the Hemabate. So it's 30 minutes either way. I would think just put the misoprostol in there, and now you have something cooking, if you will. That's a horrible image. So I don't know. Someone better tell me if I'm crazy. Oxytocin IV, Methergin IV, put in the misoprostol. The Hemabate does not sound appealing. I guess if the patient was still in uterine atony, you want to give it. But tell me if that's crazy. If just those three, leave off the Hemabate, but I don't know. Talk to your OBs. I'm sure someone's going to tell me, Scott, just give the whole kitchen sink stuff. You're overthinking. And that might be the case. And I'm fine with that. I'm fine with giving the carboprost Hemabate. Does not make sense to me to give this stuff IM. It also doesn't make sense to me to put it into a bag of 1,000 cc's and let that drip in. That doesn't seem like a great way to go either. So tell me what you think. If any listeners are OBGYN, tell me what you think. If anyone has specific thoughts about this, I'm super curious. But again, the proviso, don't go out and do this without talking to someone else first, because I'm just some idiot resus acute critical care doc. I'm not an OBGYN. Okay, great. All right, so is there anything else on tone before we go to trauma?
As you mentioned it up front with regard to these tamponade type advice.
Let's hold off on that, I think.
Okay.
You probably would not be doing that at this stage until you've exhausted some other stuff. Is that correct?
Correct.
Okay, great. So now both the trauma and the tissue requires either examination or palpation. But if you're doing the uterine compression, so where does the search for trauma? Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. And search for retained products fit into the progression here. Are you just empirically trying compression for a little while and then doing a search for these other things, or is it really, in real world terms, you do a quick search for trauma, a quick sweep for retained products, and then you'll start your compression cycle? Which way does it really?
What you said, the latter, which is that you're going to also think about what are your risk factors for trauma. For example, was there a placental abruption or some issue, mom got an MBA or something of that nature, then you're more suspicious for that situation. And then in terms of tears or trauma lacerations to the cervix, that would be someone who was pushing and they weren't completely dilated, or someone who was in protracted labor for a long time. The cervix is just sort of like hamburger. There again, you want to get exposure and look at the cervix, and or you can palpate it sometimes and you can feel a tear.
All right. And are you going, I assume you are, would you recommend a ED doc in this situation actually go all the way into the uterus and sweep around in there and see if there's any retained tissue?
Yes, I definitely would, as far as the tissue is concerned. And I think anything that I'm talking about, any emergency room physician could definitely do, right? It's just a matter of, I think one of the biggest things is visualization, right? Is like a lot of this is just palpation, as you're just feeling. You can also look at, with an ultrasound on the outside, get one of your colleagues to look at the uterus as you're watching your hand go in there and scrape to make sure that there's nothing in there. And you'll see, I think the uterus looks kind of like a golf driver and when it's normal. And so you see this like kind of like thin endometrial stripe, less than 2 centimeters would be considered. There's no clot. Sometimes you'll see a little schmutz in the lower segment. And so you can have someone do an ultrasound as you're putting your hand up there. And then you're all the way at the top of the uterus. You're getting to the top.
Very cool. They talk about placental inspection. Is that give any legitimate information, like from a non-expert? And you obviously may be able to, if I just looked at a placenta, could I say, ooh, that looks nice and whole. I think there's not retained tissue versus, ooh, there's a big divot there. That's probably a problem.
Yes, I think it's good. It's just that sometimes you can have these bilobe placentas and whatnot, and abnormal placentas that don't always tell the full story. So there's no harm in gowning up and evacuating the uterus. When I do a bimanual, I'll usually give 2 grams of Ancef after that, just as prophylactic antibiotics. But there's no harm in doing that. And again, I guess the only downside is that you will need to give some kind of medication for sedation, not moderate sedation, clearly, but that's usually the rate limiting step. People don't want to cause harm, but literally they're just delaying the inevitable by not causing harm or
what I was
pain,
asking
I should
about,
say.
let me make sure I got this, Joe. I was actually looking at the placenta. Is that worth it for me, or am I not going to be able to see anything helpful?
I think it's definitely worth it. You can see the membranes around it. It looks like it's pretty much intact, but sometimes you'll have these bilobe placentas that it looks fine, but there's another piece still in there that you didn't catch. Yeah.
Okay, good. And I guess this brings us, we'll hit rewind for a second. They've delivered the baby in this rural ED. And now the placenta is still there and mom's hemorrhaging. Do we do anything as an ED doc, not as an OB, in terms of trying to make that delivery of the placenta quicker? Or do you not recommend a non-expert do anything?
No, I think you're more than capable of handling this situation. We talk about it, the first, second, third stage of labor. Third stage of labor is removal of the placenta. So active management would be give the Pitocin and uterine massage. So this is where you want to massage it like you're giving an aggressive back rub to the uterus, and then gentle traction on the cord. Just as a caveat, if this is a preterm delivery, those cords are pretty anemic. They'll just break. And then now you have a cord avulsion. Now you have another problem to deal with. I don't think the traction on the placenta is the be all end all. It will separate on its own. It's designed to do that. With the massage will help that, and the Pitocin clearly. Then we say 30 minutes. So a normal placenta should separate within 30 minutes. If it doesn't, then, and if you're seeing profuse bleeding before that, before the placenta separates, then I would recommend going to an OR or getting an anesthesiologist there, because once you start trying to pull a placenta out in bits and pieces, that's when you're going to get the massive hemorrhage.
Got it.
So you want helpers there with you.
All right, that's fantastic. Anything else we should talk about in terms of trauma or tissue?
I would say again, to the point of compression, right? You can do a lot with trauma with just manual compression. So we talked about the physical compression of the uterus, but if you do have a huge laceration, I'm sure you've seen a lot of vaginal lacerations from non-obstetric as well, and other trauma to the vagina, gunshots, etc. So what I like to do in this case, where most of the bleeding is going to be, is somewhere close to the cervix or in there. So I'll put a speculum in, and then I will roll in. So the reason why I put a speculum is just so that to open up that vaginal canal. And then I roll in the Curlex or the vaginal packing or what have you. Some people nowadays will even soak it in TXA. There's another plug, or thrombin or whatever you have. But I haven't personally done that, and I'll roll it in. Sometimes I'll soak it in betadine and squeeze that out. But all you're really trying to do is that enables you to take a ring forcep and just pack and layer it in like taffy against that cervix. And you can stop a lot of bleeding while you're getting help to deal, for example, in those cases of severe cervical lax or bad, what we call sulcal tears, which is the sidewall of the vagina.
Okay, that's fantastic. And I can't imagine anyone non-OB would ever do any suturing of those kind of things. And I imagine in an exsanguinating situation, you folks wouldn't even be doing that. You'd be doing packing, much akin to what we do in trauma. Is that right?
We suture the cervical latch. You have to, otherwise, it's just going to potentially keep going. But that's a case where if you, it's not an easy, you're getting your hands way in there with,
Yeah.
it's not easy. You need lighting, you need exposure. But again, trying to figure out what is really going on. One thing that you can do is, again, this is a time where I've used that external aortic compression, get a friend or medical student to step up on on the code step and just compress all the way down, feel the femoral artery if it's decreased. You're really just trying to decrease the pulse pressure so that you can get a chance to see what's going on. And then we were talking about making a sponge stick or ways to clear out that, get some suction so that you can suck out the blood is very helpful. And then I'm a big fan of those disposable speculums that we have in the emergency room or anywhere, these guys that have little lights on them.
Yeah.
Okay, you know what? Sorry, I was trying to shit.
No, perfect.
You can get those you can pull them apart and use them as retractors. And then you have a light built right in there that can help you see what's going on. So this is true of vaginal trauma as well.
This is jumping ahead a little bit. I think it's worthwhile based on what you just said, but just contextualizing this from a critical care perspective without the OB side of things, it makes a lot of sense to me early on in these cases to get a common femoral artery arterial line that's 18 gauge or above, because that's going to be a conduit for where I think I would go on a really sick patient who everything's not working on, which would be Reboa. But that also will now allow me to do external aortic compression and know instantly based on the device rather than having to have someone palpating a femoral pulse whether that compression's in the right place or not. Have you ever done that, show, as both an intensivist and an OB?
No, I haven't, but that's a great point. I think I've definitely done the poor man's where you're compressing from outside and inside, and even one case where the uterus had blown up. Basically, I was compressing as they were doing the hysterectomy. I was like an additional staff, and I was compressing from underneath through the uterus to the
Wow.
That was interesting. But again, we had some helpers in that case. One point that you made me think of is if access can be problematic when these patients roll through. So just remember, if you are going to put in an IO, that it needs to be north of the umbilicus, right?
Yeah,
so
there you go.
It's so reflexive to put one in the lower extremity, but you really do need that humeral IO.
Yeah, I'd say if you're going to put a central line in, same thing. You've got to go up in the neck. So that's a fantastic point, Joe. Thank you. All right, so then let's move to thrombin. And obviously, the coagulopathy of bleeding is going to contribute, but there's some specific OB situations that really put the patient at risk for postpartum hemorrhage and for clotting. And the two I have on my list are abruption and amniotic fluid embolism. Are there other things we should also talk about under thrombin?
No, I think that's a great place to start.
All right, so let's start with placental abruption. How would that present in a rural environment, and what should make us cued in that that's a problem, and then how do we deal with it?
Vaginal bleeding is usually what the big sign there is, and pain. If you have a posterior abruption, you may not always have pain, so that can be missed. And then what happens is there's this interface with the placenta. It's like you want to be able to clot, because if there's bleeding, you want the bleeding to stop, but you also need this laminar flow in order for the little guy to get the blood flow, right? So what happens is when there's an injury of that interface between the uterus and the placenta, then tissue factor just gets puked out and from the cascade, and then starts this whole consumptive coagulopathy. And so when you think about like what is the most useful lab value to get, in my mind, it's fibrinogen. So most moms are running around with a fibrinogen of 400. That's what Mother Nature wanted us to have when we deliver. And in fact, less than 300 is like the fifth percentile, to give you the numbers. And we've seen badness associated with less than 200 of fibrinogen. Now, that's not to say you start transfusion cryo and FFP with less than 200. It's just that basically just fasten your seatbelt, because this is going to probably be a massive hemorrhage. We're going to have not just the structural anatomic bleeding, we're going to have to deal with medical bleeding as well.
I had this later on, but now we'll talk about it now. So what number do you like to see when you're actually doing a massive transfusion in terms of fibrinogen on these patients? They're actually in the midst of postpartum hemorrhage. How high are you pushing it, Joe?
I like above 200. I think that we know from obviously, and you talk about over 100 is when you start, or less than 100, you're thinking spontaneous bleeding, less than 80, some trauma surgeons use. But I like to see over 200 in these cases. And I am a fan of cryo, just simply the fact because you're talking about massive transfusion is going to come with massive volume. And cryo, you get more bang for the buck, right? You get the 5 units or so, and you've got 50, an increase in 50 of your fibrinogen versus like you're giving FFP and you're getting 10. So
Yeah.
it's just not as much of a bang for your volume buck, if you will.
Though I imagine it's because you guys don't have fibrinogen concentrate yet, or you probably switched to.
Correct.
Yeah.
Correct.
Okay.
Obviously, in a beautiful, perfect world, whole blood would be available and that would solve a lot of problems, but
Well,
that's
even
not
in
there
places
yet.
that have whole blood, like we do, you usually lose it's you don't have access to it after the first few. So everyone's on fractionated products by the midst of a resuscitation, even in place access to it. All
That's
right.
a good point.
So that's abruption. You're pretty much going to treat it the same because there's not too much else you could do, correct? In terms of being an ED doc versus an OB. So that's just buckle up, but there's not too much different you do in terms of your management strategy. Is that correct? Sure.
Correct. And remember that in abruption, the answer is obviously deliver the baby. So now one good thing from an emergency room physician standpoint is a lot of times we'll say abrupt the baby out. It causes you to go into this very quick labor. But if not, the question is, what are you going to do? Because you're going to probably lose the baby in that scenario if you can't get the baby out with the crash C-section. But again, most of these critical access hospitals do have a general surgeon, and I would call for your help because you're going to want to deliver ASAP. Can you labor with some vaginal bleeding and all that? Yes, you can, but again, you just want to look at the fetal heart tracing and make sure it's okay.
All right. Amniotic fluid embolism, petrifying. It's a bad gig, right? We don't need both vaginal bleeding and systemic disruption. Tell us about that. Tell us what we should suspect and then how to actually deal with it.
I think that what I think of it as is one of its new names is this anaphylactoid reaction of pregnancy. It's not necessarily, oh, I'm going to find fetal hair, what have you, in mom's lungs or something like that. I think that it behaves a lot. The common pathway of badness and maternal mortality is the right heart failure, which shout out to you and Sarah Prager with the right heart failure lecture on EMCrit. I think I've listened to it like 5 times. It's like
So
my
good.
Finding Nemo. But how do you get there is you can get there a lot of ways in our conversation here. One is AFE. It typically happens where you see this just apoplexy of where you lose your blood pressure and you get hypoxic very quickly. And I think really the issue, almost like a massive pulmonary embolism, very similar. It's hard to differentiate the two in that its onset is abrupt and it can be time course related to a rupture of membranes or even some induction agents. Cervidil is not used in many places, but I've seen it happen potentially with that. So there's different times when you can be at risk for it, but pretty much anything goes. So it really behaves like a massive pulmonary embolism. And then it causes this, just like everything is clotty becomes bleedy in that it becomes dysfunctional. You get this microthrombosis and then DIC picture.
Is there
But not
anything?
always. It doesn't go into florid DIC all the time. I've seen it. The big thing is to just step back for a second. And when you see something like acute hypoxia and hypotension, always think common things common first before you go to the zebra of AFE. Think of hemorrhage. Are they bleeding? Think of pulmonary embolism, probably more likely than an AFE, because your management is going to be very different. So I always, whenever someone with the hypovolemia, I always think, or rather hypertension, I think bleeding first and obstetrics.
Absolutely. All right. Is there anything different from postpartum hemorrhage that we would do in an AFE that we would not do otherwise?
No, I think the managing the coagulopathy, managing the risk of the right heart failure, the just in terms of again going back to that volume status, being able to really assess that ventricle is going to be critical and just good perfusion because obviously that triad of your acidemia, your hypoxia and your hypercarbia. You really have to keep an eye because, again, these patients are great until they're off the cliff. Something else that can behave similarly is a fetal demise, which I should have put this in there because I have seen some tragic cases with fetal demise, either the PPROM case where the baby dies and it's expectant management because the laws changed. Not everybody feels comfortable delivering that whole thing. And so now you have these women carrying a ruptured membranes and then they have a fetal demise and then they're already auditioning for a coagulopathy with a septic type picture. And then you add the fetal demise onto that. I think it adds. And I've seen this coagulopathy happen with fetal demise as well.
All right, there we go. All right, let's say they are still bleeding after all of those 4 Ts. And now in my mind, we have 2 options, and you'll tell me which one you would consider first, or they happen simultaneously. There is Reboa, and there is balloon tamponade. Which one happens first in your management?
I think again, source control is always my option, right? Is compression of whatever, it's a bullet or it's a baby that was too big. Now that we got tone issues. So source control is the biggest thing. So I would say tamponade issue, and I've done this you don't have to have a Bakri balloon where you are. You can take a condom and a Foley, Red Robin, or those just, what do you call them? Just straight casts, right? Yep. And or some type of device and sutured around there and blow it up, and you've got now a uterine tamponade there potentially. Or put a bunch of smaller Foleys in the uterus and blow several of them up with 60 ml. And so you're not really necessarily trying to compress and tamponade, but what you're doing is you're changing the pulse pressure from the aorta to the uterine artery. So that's where that's helping. There's other devices out there now. Jada is good, but a lot of remote places don't have these kind of devices. Yeah.
What the remote places should have, and I really stress it, is some form of gastric occlusion balloon for variceal bleeding, which seemed perfectly utile for this. The gastric balloon has a very large volume. If they were to put that in, does it work without vaginal packing, or is vaginal packing, should it just be tacked on to that? But here it seems like it could easily slip out. Just give me some of the hands-on experience of placing these balloons and how you actually would do it in a real situation versus people talking about it in story form. How does this work out?
That's it. That's a great point. Actually, the only reason I knew how to do a regular GI balloon was because I was like, oh, this is like a Bakri balloon. But you don't put saline in it. But anyway, so yeah, you would put the saline in this GI balloon. And then, so the issue is what you're trying to do is basically until the uterus contracts and spits it out. That's what you're hoping for, right? So there's 2 schools of thought. One of it is that, it's going to come out. My thinking now is if it's coming out, then that's good, right? Because that means the uterus contracted down and spit it out like a baby, essentially. So that's good. The reason why it could be, and as long as you know this is a risk factor, is in women who are obese, for example. It confounds everything that we're talking about here because it's hard to compress the uterus. It's hard to visualize. So if you pack, they can hide a lot of blood in the vagina. And I've seen that scenario where they're bleeding and they're profusely, and it's not recognized because the vagina is so well packed. So you recognize it by the hemodynamics, but you're not seeing it from the outside. So it's just something as a caution.
How many cc's of saline would you put in that balloon?
We put 500 cc's in a Bakri balloon to give you a sense of it. Whatever you feel comfortable stressing that to. Yep. Yeah. Yep. Or you could put a few in, or you can add things in there and put another one, or put one of those 28 or 22 French Foley catheters and blow that up to safely to 60. Yeah.
All right. Just to summarize that tamponade T. So Sho was mentioning the Bakri balloon. That's an OB specific device. I don't think many EDs should have this. I don't even think it's necessary. I think what you should stock is the Blakemore. Every ED should have a Blakemore. You're not going to use it. It's going to sit around. Replace it when they expire. Yes, you'll be wasting $150. It's worth it for that variceal bleed that just happens to come once every 5 years. And that means you need to train on it and you need to know how to use it. And that's why I think that's what you should be using for this postpartum hemorrhage, which maybe you'll do once in a career, because if you do a yearly training on the Blakemore, you'll know exactly what to do. And what you're going to do is either cut off that long tip. Don't even come close to the balloon. Leave a good inch between the balloon if you're going to cut it. Otherwise, just fold it back. Either way is fine. I kind of like the idea of cutting it because then it really does serve as a nice understanding of whether there's still bleeding in that uterus or not if you have bleeding coming out of the end of that. And then inflate it to 500. And you are basically going to do exactly like you do with the gastric balloon. Don't inflate the esophageal balloon at all. You don't need that. It's just a gastric balloon. And the only thing is you'll use saline instead of air. Saline instead of air, cut off the tip or fold it back. And now you have a perfect version of a Bakri balloon. And I think that's the way to go. Now, Sho also mentioned the Jada device. The Jada device, unlike the balloon, which is basically filling the uterine cavity, this sucks down the uterine cavity. So this is a device you put in, you inflate a balloon just to keep it in place in the end of the uterus, and then you attach it to suction. And it just involutes the uterus around the device. So it sucks down the walls of the uterus. So again, I really doubt any ED is going to have that. Maybe if you have a active high-risk OB service, they're going to bring one down to a postpartum hemorrhage call. But I don't think you as a provider in the ED will ever see or touch this device individually. All right, let's get back in. Now, Reboa, I feel, is underutilized. And by the time it's called for, access of that arterial system becomes a real problem. You'd rather do that before the pericode state, which is why I think we probably should be stressing arterial line placement early on. How often is your center using them? Some of the places I've worked at, they ostensibly have it on their protocol and it never gets done, to the point where patients are going to the OR for uterine artery ligation when they could have had a Reboa before that and had a much safer. Why do you think, A, there's not uptake, and B, if you had your druthers, how early on would patients be getting that zone 3 occlusion through a Reboa device?
I'm always someone who wants to say, as we say in the military, left a bang before somebody falls off the cliff. Let's stop this from happening. So if I were to, first of all, I don't work in an institution that routinely places Reboas for things. And again, this goes back to one of the downsides of evidence-based medicine is there's one study that showed it didn't really change in placenta accreta spectrum disorder, so we shouldn't do it, or what have you. So a lot of times when people don't want to do something, they cite a study that shows it doesn't. But I would say that if you're anticipating a difficult case, like placenta accreta or something of that nature, then yes. Or straight away, like especially in a place where you don't have a lot of blood products or the platelets are in the next county or something of that nature, just do it, because how long can you sit there with your hand? And it's just going to limit your other interventions. Maybe you could get a uterine artery embolization. They're not mutually exclusive, right? So, but ultimately just emphasizing that source control is going to be the main issue here. And sometimes you just need that general surgeon at the critical access hospital to do a hysterectomy. But again, going back to that, I like what you're saying, because I think the earlier you intervene, the better, because the more you bleed, the more loss of tone you're going to get, the more coagulopathy you're going to get.
Now, no one has done the head-to-head trials. No one's done an RCT on this. I don't know if anyone will ever do an RCT on this, but there are observational trials of this, and the data in the observational trials, for whatever that's worth, is pretty impressive. And this is zone 3 Reboa. A lot of the problems of ischemia and such, they're all from zone 1 Reboa. Zone 3, you have a lot more time. It definitively works in pelvic trauma from my observations. Again, not great data on that, but you have pelvic traumas who are exsanguinating in front of us. We put up a zone 3 Reboa, and all of a sudden we have time to get them to the IR suite. They slow down, we could catch up. It's the same vasculature in obstetric postpartum hemorrhage emergency. This is what you're basically doing when you're compressing the aorta, another intervention that has no randomized controlled data, and yet we know it slows down the bleeding. So I think as a Hail Mary, this absolutely should be on the table. Now, we had mentioned it earlier, but I just really want to reiterate. I think as soon as they start looking bad, as soon as you're doing massive transfusion rather than let's give the uterotonics and get maybe let's get 1 unit of blood and we'll give them some cryo. They're fine though. I think they're okay. But as soon as they are looking sick, I think you should get femoral arterial access, and maybe you should even get it earlier than that, because it's going to be a real pain in the ass to get it later on because they're going to want this woman's legs up to be able to do all the other stuff. So an art line is a great thing to have. I think you should just place the art line, something 18 gauge or above, early on. As soon as you identify as postpartum hemorrhage, just place a common femoral art line. And then, having good access later on, you could work with, because you don't need to go to the legs. In fact, as mentioned, it's probably not ideal to go to the legs. So we could work on the neck as they're doing all the stuff down at the birth canal. But getting that femoral art line in early just changes the game on getting Reboa, because all the problem with Reboa is getting it in. And all of the problem getting it in is getting good arterial access. So if you already have, at the very beginning, when the patient's blood pressure's good, maybe they're just looking a little bit sick or their blood pressure's a little soft, getting femoral arterial access in the common fem then is the game changer. And all of the Reboa studies in trauma too suffered from the fact that they had a lot of trouble getting this in quickly, and all of the trouble was getting that arterial access. Because once you have the arterial access, converting to Reboa is not hard at all, and it's very quick. So here's a plug. Get early access, common femoral artery. Even if you're never going to go to Reboa, having an art line is key. Having a central art line is really nice. It should not get affected by putting the legs up, just given the location of where the common femoral artery is. So I think early common femoral arterial line is key. This is not a study for looking at EverDAC and saying they don't need arterial lines. This is not that case. All right. And I guess the last T that the Brits added on is theater. At what point would you transition to the operating room in these cases?
I try to think about the rest of the team, right? Because if I was an anesthesiologist, where would I want to be resuscitating the patient? In the operating room. So I'll give you an example. Sometimes you have which is good to talk about, is a stuck placenta. Your fire department delivers a baby, and then now the placenta is still stuck. It's 30 minutes. What are you going to do? So you're going to have to go after it. And the way that I think about going after it is just finding the plane. It's like you gown up, you got your sterile gloves, you put some lube on the back side of your hand so that you have some dexterity in your fingers, and you find that plane, and you just dissect manually that placenta, and then you kind of start to feel it. You can grab, and then you pull it out. Again, try to avoid the chunk thing, because that causes some massive bits and pieces. And then unless you could do a DNC, and even those suck, because then the uterus can perforate and all that. So I would say that unless you can completely remove a placenta, then in whole, then go to the operating room, or someone's going to need resuscitation. If you have an operating room available, I always do it, unless you just don't have time. I'll give you an example. There was a trauma woman came in, and she had a placental abruption. She's bleeding out. There wasn't even time to do a stat C-section right there, compress the aorta against the sacrum, and she lived. Baby didn't live, but she did. Yeah.
Mm-hmm. All right. We talked about so much, Joe. Is there anything we missed for postpartum?
I think, again, going back to early recognition is probably one of the biggest things, is because you talk about the shock index, which is great. And a lot of people will say that's not validated in pregnancy, and nothing is validated in pregnancy really, but it's showing you a trend of where you're going to. So I'm quoting Jennifer Gurney, Colonel, who's in charge of the Joint Trauma System for the Army, as salt water is good for cooking pasta, right? So it's, if someone's bleeding, replace it with blood products is my thinking. And then just getting the source control is, even 1-to-1 is coagulopathic for moms, because we're so hypercoagulable when you go into birth. And so source control, blood early, and that will go a long way.
Let's talk about what you just mentioned. So does that, let's say there was another OB there and you were just helping out. So they were handling the stuff at the vagina and you're actually helping with the massive transfusion. Do you alter from 1-to-1? How do you change an MTP on a hemorrhaging obstetric patient?
I think if you just try to keep things simple and not, I would say this with antibiotics too, and maternal sepsis, it's just give Exos. You know what I mean? It's just, you're going to be, the one thing is to just think about this fibrinogen piece and how coagulopathic they get with ongoing bleeding, and the fact that cryo has less volume. So a lot of OB, there's some places that have, instead of an MTP, they'll have an OB hemorrhage kit. And that usually comes with 2 of FFP and 2 of Reds, and then 1 of cryo, and then plus or minus. So there's variations thereof, but I would definitely say that try to get that cryo in early if possible.
That's a fantastic tip. So when let's say with that first delivery of an MTP, would you be getting 5 units of cryo or 10?
With an MTP, most of them will start off with 5, as that's 50 of fibrinogen. So I think that's a good place to start, and then you start getting more with it. And don't forget our friend calcium. I love TXA and calcium. It's kind of like the no-brainer. You're not going to kill someone with calcium in this scenario.
Love it. Love it. Anything else we missed?
No, I guess the most important thing is just thank you, Scott. I've been a fan and a listener since I was a med student. So it's just really appreciate so much of what I've been able to deliver at the bedside, even in the OR and certainly in the ICUs, because of listening to you and your guests and the perspective. And then also just really, as we think about the direction of obstetrics in our country, more and more obstetric units are closing throughout the country. We lost, I think, 18 units when I was in Iowa, University of Iowa in the state. And so when I say obstetric units, people that have people like me,
Yeah.
right? And so now it's people that are out there on the front line, your listeners. And so I just appreciate your passion for this patient population and can't thank you enough, because I know your job is becoming more and more demanding every day.
Wow, this has been fantastic, and thank you for your kind words. And I will tell you, I know what the listener is going to say because I know what I'm feeling right now. We would love, love, love to have you on for additional episodes in this OBGYN series. It would be a true pleasure. So hopefully you will.
Oh,
hear
likewise,
more from you
be a
shortly.
privilege.
All right.
Thank you so much, Scott.
As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.